When there is a health-related event or condition that affects a population, and by population we mean a large number of people, whether in a neighborhood, a school, a city, county, state, country, or global, and we decide to look at it critically by using a systematic approach based on valid research and well-founded scientific knowledge, and by carefully analyzing accurate and reliable data. We do that in order to have a better understanding of it, to see to what extent and how rapid it affects the population, and perhaps how differently it may behave depending on what segments of the population, the old, the young, female, male, ethnic background, etc. We also wish to know what may bring about such health-related event or condition, what is the cause, and who may be affected by it. This science-based systematic approach is useful in analyzing and understanding COVID-19, which again is an infectious disease. But this method doesn't have to be just for infectious diseases. It can also be applied to diabetes, hypertension, stroke, heart attack, or non-infectious diseases. And in fact, this method also is not limited to diseases, but it can also be applied to natural disasters, injuries, environmental exposures, and even terrorism. What we have just gone through, as copied straight from the Centers for Disease Control and Prevention's website, or the CDC's website, is the definition of epidemiology. Or borrowing another definition from Wikipedia, epidemiology is the study and analysis of the distribution, the who, the when, and the where, patterns, and causes of health-related conditions in certain population. Epidemiology forms the foundation of public health, and it draws from the scientific knowledge and practice of many other fields, including biology and medicine, statistics, as well as social sciences. Why do I mention epidemiology? It is because when we look at COVID-19 as a disease, it is much more than just looking at SARS-CoV-2, the virus. When we discuss the disease COVID-19 beyond what the virus SARS-CoV-2 looks like and how it replicates and how it affects our bodies, we begin to consider how such disease starts, how it spreads, especially how fast it spreads and how widely it spreads, and how it affects all of us as a community, as a population, how much of a burden it is on our healthcare system, how adversely it can affect a family's financial situation, a business's revenue and its workforce, and our economy as a whole. At this juncture, please allow me to take a detour to briefly discuss an interesting and seemingly unrelated concept, as well as to make a disclaimer. During the process of educating myself about SARS-CoV-2 and COVID-19, I recently came across an online article dated April 21, 2020, titled "The Dangerous Rise of COVID-19 Influencers and Armchair Epidemiologists," in which the author interviewed the social psychologist Dr. David Dunning, who, along with his colleague Dr. Justin Kruger, introduced the social psychological concept of Dunning-Kruger effect in 1999. Discussing further the Dunning-Kruger effect in this video would be digressing too far from the matter at hand, so I would just refer you to read about it. But going back to the online article about the armchair epidemiologists, from the insight of Dr. Dunning as well as the article's author came the following warning, that there are, and I quote, "men, and they are largely men, who are legitimate experts in other fields. They are lawyers, former reporters and thriller writers, Silicon Valley technologists, newspaper columnists, economists, and doctors who specialize in different parts of medicine. Their utter belief in their own cognitive abilities gives them the false sense that their speculation and their predictive powers regarding COVID-19 are more informed than the rest of ours." Unquote. My disclaimer is the following. I am not an epidemiologist, and I certainly do not wish to fall into the category of armchair epidemiologist. I am a radiologist by training, and my medical background helps me to understand certain scientific terms and concepts, but I do not claim to be an expert in epidemiology, or for that matter, virology, microbiology, infectious disease, pulmonology, and as we will soon see, statistics and statistical modeling. What I am trying to accomplish in this video, or this series of videos, is to distill the various information about SARS-CoV-2 and especially the COVID-19 pandemic, and hopefully to bring into focus this pandemic and its ramification for a specific audience, the many students who have to be educated remotely while being confined in their homes. With all that said, let's move on. Let's talk about the now familiar EPI curve, which is short for either epidemic curve or epidemiology curve. Both are used interchangeably. But first, let's get familiarized with the notion of exponential growth and doubling time. We will be conducting a totally hypothetical and very simplified experiment using 1 million mice. We will infect the first mouse on day 0, say just minutes or seconds before the start of day 1. And will require that the infection causes no morbidity and no mortality. Morbidity simply means sickness. Mortality or fatality means death. In order to have no morbidity and no mortality, let's say that the virus that we will be infecting the first mouse is benign, and that it will only cause a blue patch to appear on the fur of the mice, without causing severe sickness or death. Our experiment will also require that we let the infection run its course without intervention. And finally, our last requirement is that each infected mouse can infect one more mouse per day. We will now log our findings in this spreadsheet. On day 0, our first mouse is infected with the virus, and at the start of day 1, it shows the sign of infection in the form of a blue patch on its fur. It runs around, and by the end of day 1, it has infected one more mouse. By the end of day 2, the first 2 mice managed to infect 2 more mice. By the end of day 3, those 4 mice infect 4 more to make 8. By the end of day 4, 8 more mice are infected to make 16. By the end of day 5, 16 makes 32. By the end of day 6, 32 more makes 64, and so on and so forth until we get to day 20th, when all 1 million mice will have been infected. Now let's run the experiment again with another population of 1 million mice. Everything remains the same with the same virus, no morbidity, no mortality, and let the infection run its course, no intervention. But this time we're going to change the requirement that each infected mouse can infect one more mouse every 2 days instead of every day like before. And so the recording on our spreadsheet shows 1 infected mouse on day 0. A second mouse is infected by the end of day 2. By the end of day 4, that doubles to 4. Another 2 days bring it to 8. Another 2 days double to 16, and so on and so forth until we get to day 40th, when all 1 million mice will have been infected. If we keep running the same experiment, but only changing the number of days until another mouse can be infected, then we will have the following charts which range from every day to every 8 days. These charts reflect the doubling times or doubling rates in each of our experiments. From the far left of doubling every day, moving to the next one of doubling every 2 days, and then doubling every 3 days, and so on until the last one on the right at the doubling rate of every 8 days. The following are just some interesting numbers. If the infection rate is 1 new mouse every day, then starting with the first mouse on day 0, we will reach 1,000 mice by day 10. If the infection rate is every 8 days, then it will take 80 days to reach 1,000 mice. Another milestone in these charts is the number of days it takes to reach 1 million individuals within a certain population. We will now take a look at 2 particular doubling times. One is doubling every day and the other is doubling every 4 days. We will first plot the data using the bar graph for the doubling time of every day. As you can see, the bars get very tall very rapidly, so that after day 6, we are already running out of room on the slide. And so let me regraph it using another set of axes. And in the case of doubling rate of every day, we reach 1,000 mice by day 10. We can also use a line graph or a curve graph, which can follow the peaks of the bars. Either type of graphing shows the typical curving upward of what is called exponential growth. And as in this case of doubling rate or doubling time of every day, the curve rises very steeply, very fast. When we graph the data for the doubling rate or doubling time of every 4 days, the bars are of course more spread out over a longer period of time. Now let's superimpose the 2 graphs onto the same axis. The curving upward shape of each graph is very similar to each other and is representative of exponential growth, but of course the rise or the slope of the orange curve is more gradual, less steep, because it reflects the doubling time of every 4 days instead of every day, as represented by the much steeper red curve. By collecting data on an infectious disease and using this type of graphing, we can follow and characterize such disease. Let us run another experiment, and this time we are going to make it more manageable by considering a smaller population of mice of only about 2,000. We infect the first mouse on day 0 with an infectious disease pathogen of unknown morbidity and mortality. We will also let the infection run its course without any intervention. The bar graph for the first 6 days shows that the rise in number of infected mice is quite steep and rapid, with a doubling time of every day. At this rate, we expect to find 128 mice infected on day 7. On day 7, however, we record 120 mice instead of 128. And on day 8, instead of doubling from 120 to 240, we record 180. And so it looks like the doubling rate has changed. It has slowed down. What is happening here? Well, remember that we started this experiment with a pathogen whose morbidity and mortality are unknown. Even though the first 6 days showed a doubling rate of every day, in this hypothetical case, those many dozens of mice that were infected early on may have started to have symptoms by day 6 or day 7 or 8. And perhaps some of them are sick enough that they may not be up and around enough to be able to infect other mice. So, in a sense, they put themselves in isolation. And if the infection is severe enough, perhaps some other mice may have already died and therefore no longer can infect other mice, further reducing the rate of infection. This is why, even without intervention, the infection rate in this small population of mice slows down after a certain period of time. And as we continue on in this very hypothetical experiment, we see that the infection rate slows down even further until it reaches a peak on day 10. And the number of mice infected on day 11 is smaller than on day 10, and smaller still on the subsequent days. And the curve starts to go down until no more mouse is infected after day 22. Again, we can graphically represent the data from this experiment by using either the bar graph or the curve. And the orange area under the yellow curve represents the total number of mice affected during the course of this infection. This experiment gives us an example of an epi curve, and the shape of the curve is unknown until the infection is completely over, and it does not have to look like this. This is the actual curve of the current 2019-2020 flu season, as graphed using the data available from the CDC website. Each bar is the weekly number of patients who have tested positive for either type A flu or type B flu combined together. Notice the double peak with the first one peaking around week 13 and another peak around weeks 18 and 19. And this other one was from the 2017-2018 flu season. It is included here for historical interest because it had the highest number of hospitalized flu patients in the past 10 years. Now that we have a basic understanding of the epi curve, let's introduce the concept of healthcare capacity and how it relates to an epidemic. Let's reuse our previous experiment with a population of 2,000 mice in which an infectious disease outbreak occurred on day 0. For the purpose of this particular experiment, we will assume that once infected, the mice will become sick, some worse than others, and likely would need extra care. Prior to introducing the infection, we assigned 30 student researchers the task of taking care of the mice. And we find out that each student can comfortably and adequately take care of 3 mice each. So our 30 student researchers can take care of 90 mice. And one more requirement for this experiment. Beside nursing and feeding the mice, the students are not supposed to intervene in the infection. Or in other words, the infection is allowed to run its course just like in our previous experiment. And so we start the infection at day 0. And by day 6, we know that there will be 64 mice that are infected. due to the doubling rate of 1 day. But the 30 students can easily take care of the 64 mice that have been infected, even if there are mice that are sick. By day 7, there are now 120 infected mice, some being sick while others with only mild symptoms, but they all need to be cared for. And we have to ask each student to look after 4 mice each, one more mouse than they are comfortable doing. You can see where this is going. By day 8, we have 180 infected mice. And so whether or not they have mild or severe symptoms, each of the 30 students is now very busy looking after not 3, not 4, but 6 mice. And by day 9, with 220 mice infected, each student must take care of more than 7 mice each on average. And needless to say, the students are overwhelmed. And we don't really know if under stress, the students can adequately nurse the infected mice back to good health. In this oversimplified scenario, our 30 student researchers represent healthcare capacity, or the resource, availability, and ability of our healthcare system to provide adequate care. The number of clinics, urgent care centers, hospital beds, ER beds, ICU beds, nurses, doctors, ancillary care including respiratory therapists, etc. And that's not even considering the potential of some of these healthcare providers themselves getting sick. But let's go back to our model of the 2,000 mice with rampant infection, or infection with no intervention. We can see from this particular epi curve that if the infection rate or doubling time is allowed to occur rapidly, then the 30 students representing our healthcare system will be overwhelmed. This scenario unfortunately may very well occur in a human population, and we can change the y-axis to a generic number of patients and the x-axis to a generic time, which can be days, weeks, or months. In our present COVID-19 pandemic, the US is now starting its 15th week today, Sunday, April 26th, based on the date of the first reported infection as recorded by the CDC, which was on January 22, 2020. Looking at the area under the curve, the number of patients that can be adequately cared for by our healthcare system, should they become sick enough due to the infection, is the area in green. We could be in trouble if we allow an infection to overwhelm or inundate our healthcare system when the number of patients needing medical care reaches into the red zone. Let's go back to our last experiment. We have 30 students who can adequately care for 90 mice. And we want to avoid getting into the situation where the mice are infected so rapidly that we will end up in this red area. What we would want is a curve like this in the green color, with its peak under the level where the 30 students can feel comfortable, or maybe even a lower peak than that, so that at any one moment, the students are not overwhelmed, and all the mice, even the sickest ones, are well cared for. In a controlled laboratory environment, where we set up all the parameters to the experiment ourselves, and with a relatively small population of mice of 2,000, this can be quite easily done. However, in a real-life situation involving a large region with a large population, or even a whole country with hundreds of millions of people, this is quite challenging, although perhaps not impossible. If we cannot have the ideal situation as illustrated by this small green curve, where the infection is essentially minimized and halted as soon as it starts, or as soon as possible, then at least we can somehow influence the epi curve so that its peak will remain within our capacity to provide adequate healthcare to all the people who need it. What are the differences in these curves besides the obvious visual appearances? First of all, if you look at the steepness of the curves, or their slope, during the early phase of the infection, this represents the initial rate of infection, which we now know is related to the doubling time. We want to move from a very steep or rapidly rising curve to a more gradually rising one, if we want it to rise at all. The dark orange curve to the right has the gentlest curve, which indicates that its infection rate is the slowest, or in other words, it takes many more days for one infection to result in the next infection. The second difference in these curves is the peak, and the time it takes to reach the peak. In our experiment, when we let the infection run rampant without intervention, we reach a very high peak very fast, and thus the red area under the curve is frighteningly large. But as we influence or make some changes in the experiment with the mice population, the flatter, darker orange curves start to peak lower and taking longer to peak. This is called flattening the curve, with the end result being that even at the peak, 30 students can adequately care for all the mice that are infected and need care. So how do we modify our experiment to get the curve to flatten? Here's our curve from the original experiment of the 2,000 mice where the students were asked to care for the mice, but to let the infection run its course without intervention. This time, we will still infect the first mouse on day 0, but instead of letting the infection run its course, we ask the students to intervene. An intervention is based on a very simple but valid concept: not getting oneself infected, and if infected, not getting others infected. If the students intervene, depending on how early on they detect that there is something wrong. By the way, in this new experiment, let's say that we will not inform the student when we will infect the first mouse, or in other words, exactly when day 0 is. And we will also not inform them what kind of symptoms to be expected in an infected mouse. It will be up to the student researchers to monitor the mice and see if there's anything out of the ordinary. Then they can do whatever they can to intervene. And so if the students can detect something wrong with certain mice, and depending on how early on during the infection this can occur, we can roll back the original epicurve. Let's pretend further that once the infection started on day 0, which again the students do not know exactly when, the infected mice are not yet symptomatic during the first 5 or 6 days or so. And thus during this initial phase, the infection did run undetected and therefore undeterred. There was not intervention because there was no knowledge of its occurring. But let's say by day 5 or 6 some of the mice start to have symptoms, whatever they may be, and the students spring into action. As good researchers that they are, they carefully observe and document what kind of symptoms some of the mice may be exhibiting. This is called rapid identification. And they alert all the other students so that everyone will be on the same page as to what to look for and what to do. This is called coordinated response. Then they carefully and safely remove those mice with symptoms, presumably because of the infection, and care for them somewhere away from the rest of the other mice. This is called isolation. In addition, the astute and conscientious students also pay attention to some other mice, although having no symptoms, but potentially could have come into contact with the sick mice before the latter are isolated. This is called contact tracing. And then the students would remove those also and place them away from the rest of the mice population for observation. This is called quarantine. Since the sick mice exhibited symptoms after about 6 days from the start of the infection, then a quarantine period of 6 days is prudent. Whatever the longest time it takes from the presumed pathogen exposure to first symptoms, that is a good timeline for a quarantine period, perhaps adding another day or 2 just to be safe. If after 6 or 7 or 8 days or so and the quarantined mice do not have symptoms, then perhaps they were not infected after all, and they can be released back into the mice population. If the students succeed in doing all this, then they will have succeeded in halting the infection, or stopping it in its track early on during the initial phase of the infection. This is called containment.